Hi everyone, this is Andre from Vital Hub. Thank you for joining today. Good morning, good afternoon, good evening, whatever time zone you're in. We're going to be spending the next 1 hour going through the mobile enablement that was done at Trinity Village Care Centre. We're going to be showing you a product demonstration of what the mobile application and solution looks like. You're going to be hearing from a few of the Trinity Village folks, and hopefully you'll get something out of this webinar. And at the end of the webinar we'll have some questions and answer period. But in the meantime, if you have any questions, feel free to type them into the feedback window, and we have somebody monitoring that window. Okay? All right, let's get started. So presenting today is myself, Andre Vandenberg. I'm the Chief Innovation Officer here at Vital Hub. I'll walk you through who Vital Hub is in a minute. We also have Debbie Riepert, who's the Chief Operating Officer at Trinity Village, Miller Longanilla, who is the Director of Resident Care at Trinity Village, and Laura Schmidt at Trinity Village, who is the Internal Clinical Auditor there. And they'll be talking here in a minute. So very quickly, we won't take a lot of time talking about who we are and what we do, but just as an introduction, Vital Hub, we are a technology company. We focus on healthcare software development, and we partner with healthcare provider organizations to implement our existing off-the-shelf pre-built software, and we also provide customizations and tweaking as needed for each and every customer to make it work exactly the way they need it to work. The markets that we're focused on are long-term care and mental health, where most of us are here in the Toronto office. We are a public company traded on the Toronto Stock Venture Exchange. Our symbol is VHI. And our website is vitalhub.com. Feel free to look us up and learn more about us. Trinity Village. Trinity Village is an 11-acre site in Kitchener, Ontario. They have 150 beds in long-term care, 90 adult day program space, 74 supportive living studios, and 60 townhomes. And you can see their mission statement here, and they truly live up to it. A caring community which values and fosters the work and lifestyle of all. So what happened was about 1.5 years ago, Trinity Village submitted a challenge to through the Mars Innovation Partnership Procurement by Co-Design program, and we responded to that challenge as technology innovators to come up with a solution to that challenge, and we've been working jointly ever since to create this solution that we're going to walk you through today. The challenge that was submitted by Trinity Village is this: how can we gain efficiencies for care workers in a highly regulated field for complex multi-diagnosed individuals, currently supported by multiple paper-based and electronic documentation systems? So in other words, as you can see in the photo there, and I'm sure many of you are familiar with this, a lot of paper forms in long-term care, and they still exist. Some may be on Excel spreadsheets, some might be in Word documents, some might be in binders at the nurses' stations, et cetera, et cetera. And so their challenge was, how do we bring that all together into a nice cohesive system and give our workers real-time access to this information? So the solution that we came up with, which we call VH LTC, which obviously stands for Vital Hub Long-Term Care, is a mobile solution, a mobile app running on an iPhone or an iPad that the caregivers carry around with them and can do their documentation in real time into those forms. So all of those paper forms that you're used to using today, such as dementia observation screening and restraint forms and head injury forms, etc., they now are all inside the app running on the iPhone. Now, it's not just the entire form that we put in the app, because that wouldn't be very productive just to put an electronic version of the form in an iPhone, because it's too small to read. So we broke each form apart into logical bite-sized pieces and allow the users to enter only the information they need to enter at that point in time for that particular resident. And then it all comes back together into an actual form at the end of it all. And we're going to walk you through that in the meantime. And what we want now is for Debbie Riepert just to spend a couple minutes talking to you about the actual VH LTC implementation at Trinity Village. Debbie, go ahead.
Thank you, Andre, and hello, everyone. I have had the privilege of working at Trinity for 34 years now, and I began as a PSW, and so I've always been aware of the impact from changes in best practice and legislation for the frontline workers down to the management. We make organization decisions based on our mission, vision, and values here, and our vision is to be a leader in providing superior care through innovative services and community partnerships that enable people to work and live with dignity and respect. So in 2016, when we came across the Mars Innovation Partnership Procurement by Co-Design opportunity, we felt compelled to submit our challenge. We really didn't expect to have a response, but after interviewing a few possible solution providers, we signed an agreement with VitalHub. VitalHub shadowed our frontline staff and truly understood the challenges of long-term care today and saw the benefit of this solution for both workers and residents. We put together a task force consisting of PSWs, RPNs, RN, management, and VitalHub members. And together we discussed what the ultimate solution could be. We dreamt big, and after 2 sessions had our aha moment. But we wanted to validate our innovation. And so we met and shared our vision, challenge, and solutions with Health Quality Ontario, RNAO, the LIN, and Apple. We discussed, does the solution make sense? Are we on the right track? We were pleased to share that our project was the top winner of the first Mars cohort. Our solution became not only for us, but one that can benefit the long-term care industry, improving worker well-being and resident care. Ultimately, better data for better outcomes. Let's provide all care workers with schedules at their fingertips. And I ask you, would you give up your Outlook or electric calendars and go back to a paper day timer? Back to you, Andre.
Thanks, Debbie. So let's continue now and talk more about what is VH LTC. What is this mobile app all about? And why has it been so successful at Trinity Village and other long-term care homes in Ontario? The first thing is that we took the forms that are most needed, that are currently being managed in binders, and we put those into the app first and foremost. So for example, dementia observation screening. So everybody knows how this works. It's about a 7-day observation period. Observations occur every 30 minutes. And you generally have an option of identifying that the resident is sleeping, they're calm and awake, they're anxious, they're agitated, whatever. And this, you probably have a form that looks something like the blue one on the left-hand side of this screen. What we did is we took that form and we created a special little dementia observation screening form that allows you shift by shift to enter all of those time slots. So for example, on the right-hand side, you see dementia observation screening, and you see 7 o'clock, 7:30, 8 o'clock, etc. So only the shift that I'm working on right now for this resident is the section that I need to see of this form. I don't need to see the whole form right now when I'm doing my observations. So we broke that form down into a bite-sized, workable screen that is displayed on the iPhone. If you look at the next form, restraints. Restraints is always done as, sorry, the screen seems to be having a mind of its own here. Just going back for a minute. The restraint form is typically done every hour and then every 2 hours the resident needs to be rotated or moved around. And you're going to record things like, did I apply or did I remove the restraint? Did I check and did I rotate or reposition the resident? And what was the resident's response? So this is information that's being entered, and the form on the left side of the screen right now is the complicated form that you may be using today. On the right-hand side is the way it looks in the app, where we broke it down hour by hour, very simple checkboxes on what you did to observe the restraint. Here's another one, head injury routine. Now, this is a particularly unique one with head injury. Head injury happens depending on your routine, but typically the first hour or two you're supposed to observe every 15 minutes, and then the next hour or so you observe every 30 minutes, and then the next 3 or 4 hours you observe every hour, and then the next, et cetera, et cetera. You get the point. That's a difficult thing to deal with in an application electronically. What we did, as you can see on the right-hand side, is we get the nurse to go ahead and record the first initial assessment, which in the example you see on the right-hand side occurred at 7:43 in the morning, where the resident was available, their systolic was 105, their diastolic was 95, their pulse was 75, etc. And once you record that initial 7:43 assessment, it then stamps out all of the next set of time slots. So you can see 7:58, 8:13, etc. So it now knows when those next assessments are due. And to the point where if you want the application to, it can even remind you when those assessments are due. And in the bottom right corner of this slide, you'll notice we do things like visual representation of some of the observations. So for pupil size, 2 millimeter, 3 millimeter, 4 millimeter, it's actually showing you the real size. Not in this slide, obviously, because the screen is shrunk down. But in the app, it's the real size. So when you see 2 millimeters, you can hold it beside the resident's eyes and you can see, oh yeah, that's 2 millimeters. Oh yeah, that's 5 millimeters. Things like that. The other thing is bath schedule and skin inspection. Bath schedules can be complicated, typically twice per week, as you know, and different residents have different preferences as to who does their finger and toenails and who does their hair and so on and so forth. So it can be complicated to manage that schedule. And also, along with the bath, when you give the resident a bath, you do a quick skin inspection. Not a full skin assessment, just a quick skin inspection. So we have a built-in little inspection tool where you can identify any skin issues. And you can even draw in a little picture, as you see on the right there, if the resident is showing redness on the right shoulder, where that redness is, etc. So here is a summary of our current forms library. So in the summer of last year, we spent much of the summer implementing these forms. Appointment tracking tool. So it allows you to enter in doctor's appointments, dentist appointments, family visits, Tim Hortons outings, etc. That can all be entered into the system. So when the PSW sees his or her list of residents and tasks, he or she not only sees the clinical care-related tasks, but also if there's a physical appointment coming up, such as a family visit, that they can't work around. They have to work around that particular schedule. If the family's showing up at 10 a.m., they're going to be there at 10 a.m. I better not be giving my resident a bath at 10 a.m. when the family shows up, kind of thing. So appointment tracking is an important part of the overall solution. The various observation type forms, dementia observation screening, elopement risk, inappropriate sexual abuse risk, suicide risk, etc. Those are all part of the solution that we built in the summer of last year. All the different types of restraints are built into the system, whether it be tabletop, tilt wheelchair, 10-pound pressure, front seat belt, anything like that is all part of the restraint observation records. The bath schedule and skin inspection is there, and I'm going to show you some of these in the actual app in a couple of minutes. In the spring of this year, we introduced a few more forms, the 7-day product and voiding form, the 7-day bowel record, and the head injury routine that I just showed you a screenshot of. And in this past summer, we introduced 3 more sets, the falling leaf DOS, which starts dealing with falls type forms, the pain tracking or pain monitoring form, and restorative care. And we're going to continue as different form layouts are needed for different clients. We just continue to add the different form layouts. And I'm going to talk near the end about things that we're currently working on so you know what the plan is in the coming 12 months. Okay, so now I'm going to do a product presentation. And it's just going to take me 1 minute here to flip over to my computer, or to my other screen, I should say. Just give me a second. So I'm now flipping over to my iPhone, and I'm going to display it on the computer so you can see it. Give me 30 seconds. Just hold on. Okay, it's connecting now. Another 15 seconds. Okay, I'm going to share my phone now. And now you should be seeing my phone. Okay, so I'm going to go into the application now. This is actually truly running on my iPhone right now. I'm going to launch into Trinity Village, by the way, calls this application Docket. They've branded it as Docket in their organization as opposed to VH LTC. And you'll notice the way when the app comes up, it actually has an image of Trinity Village's sign, etc. It's kind of neat. So we kind of do some of that private branding or customized branding if needed. Okay, so I'm signing in here into Trinity Village. It's just loading, and on my screen here it's showing. It's just going to take a minute for that screen to render through the screen here, through the screen sharing app. I'm going to restart the screen sharing. Okay, we finally have the screen. So the way this works is what happened when I stopped sharing my screen is I logged in as a user who is a PSW, and that PSW is currently, you can see in the top of the screen, working in Pine Woods, which is one of the units. They're playing the role of PSW-A on the day shift. And because of that, they're seeing these 7 or 8 residents that belong to them. The residents are color-coded as to whether or not there are tasks to do for them, or they would be red if there were overdue tasks, they would be green if they were all completed, etc., etc. If this was a real environment, I would see real resident photos there instead of those little gray icons you see there as placeholders. You would see the real resident photo. And I can go into any one of the residents by tapping on the resident, and I can then see the resident's tasks. Okay? So what I'm going to do now is go into a resident and start doing some charting. And you'll see how the documentation process works. So the first thing to know, if I go back to the main screen here, is you'll see a couple of icons that Darren has associated with him. So the little red leaf means that he's on the falling leaf program. So he's a falls risk. The little black circles say that he is on some rehabilitation for bed and walking, bed mobility and walking. And the restorative care minutes is what's important here. So if I decide I want to track the number of minutes because you need to reach that 15-minute threshold, you can simply type in the number of minutes here for Darren, and you can see that I now have spent 5 minutes for bed mobility, and I've spent 3 minutes for walking for Darren. And if I go back to the main page, then I can see that 5 and 3. Now, when I hit 15 minutes, so let's say I add another 11 minutes that I just spent with Darren, I'm now at 16 minutes. So it turns green saying that I've met that 15-minute threshold for today, because that's what the RAI assessment needs, is you want that 15 minutes. So now it turns green, and I know I'm done with bed mobility restorative care for this day. The red leaf means that Darren is on, he's a falls risk. And you can identify any type of statuses or risks that you want in this screen you're seeing now. This just happens to be some of them that Trinity Village uses. If the resident is on the falling leaf program, or if they're a palliative resident, or if they're on BSO workload, they indicate all those values, and they have different icons. And we can load up any icon you want to use for those various settings. So I can see visually right now that Darren is a falls risk. I can also see he's palliative, and I can also see that he's on BSO caseload. And I can see that he spent 16 minutes on restorative care for bed mobility and 3 minutes on walking. If I click on Darren again, I see all of the detailed tasks associated with Darren. So for example, 10-pound pressure, he's on 10-pound pressure seatbelt. And I've already got some data entered for Darren for the 7 o'clock observation. You can see that the restraint was applied, it was checked, and the resident was calm. At 8 o'clock, the resident was repositioned and was calm. Let me do 9 o'clock. I'll simply tap on 9 o'clock, and I'll say that I checked and the resident was calm again. I'll submit that, and there's the 9 o'clock observation. If I click on 10 o'clock, you'll notice the way I have no choice but to reposition. So it's keeping track of how many hours it's been since you've repositioned them. So in this case, I have to reposition. And let's say this time the resident is agitated. So agitated is one of those observations that escalates to the RPN. So the little alert just popped up, say that the RPN has been alerted. So the RPN just got a message that this situation has occurred, and a new task has been added to the RPN's task list to acknowledge that particular situation. So the collaboration and communication between the various disciplines and various workers is built into this system. And it's configurable as to which workers should get alerted, which workers should do an acknowledgement, which codes trigger an alert, et cetera, et cetera. Okay? So then let's say at 11 o'clock, let's pretend for a minute that I put this resident back to bed, and so I'm removing that seatbelt, and I'm going to submit that. And now that the resident is back in bed, I've removed the seatbelt. I now can mark this task as complete, which then turns it green. If I look at the dementia observation task, I'll click on it. You can see that I haven't entered any yet. So my 7 o'clock observation, even though it's currently 1:30, I haven't recorded any observations, so I've got some catch-up to do. So I'm going to say at 7 o'clock he was sleeping. At 7:30 he was calm and awake. At 8 o'clock, maybe he was physically and verbally responsive. And that's one of those escalation observations again. So it escalates to the RPN, and the RPN now knows and gets another alert and a task added to her list of things to do to address that situation. Now you'll notice I've been able to backdate observations because we all know that workers do not get to it right away. The idea is to get to it as soon as possible, so I can go back and update these observations. But I cannot go into the future. If I try to record an observation right now for 2 o'clock, it's going to tell me that I can't. So there's lots of various safeguards in the app that disallow the user to go and pre-populate things knowing that they're going to leave soon. They can't future date observations. And once I'm done filling in all my time slots for my shift, which ends at 3 o'clock, so my last observation is 2:30, once I'm done, I then could mark that task as complete. Now let's do a head injury. And let's pretend for a minute that I don't know if I'm a flex worker or a floater, and I don't necessarily know all the residents. Now, head injury is an exception because head injury is done by nursing, and of course they're going to know. But typically, if you have a flex worker or a floater, they don't always know all the residents, right? So this tells them which resident has which tasks. But they could also click on the tasks button at the very bottom. This would just show them a complete list of all of their tasks that they have to do today and for which residents it's applicable, right? So you can see I've got dementia observation, I've got the bed mobility and walking restorative care, I've got the 10-pound pressure seatbelt observation, which has already been completed, and I've got a couple of baths to provide. So let's pretend that I'm going to go do a bath. I'm going to skip the head injury for a minute. I'll change topics. I'm going to go provide my resident Ben here a bath. So I'll click on bath, and you'll notice it tells me what is the bath. Okay? Your screen is just taking a second to refresh here on the screen sharing app, so just give it a second. But when it does get there for you, you'll notice that it's going to tell me on the screen what type of bath is it. Is it a shower? Is it a bed bath? Or is it actually just a bath? And it also tells you who's doing the fingernails, who's doing the toenails and the hair. And then it allows you to do a skin inspection. It doesn't look like your screen is refreshing like mine is, so I'm just going to move the screen around a little bit to see if it'll refresh. See if that helps it. Okay, every now and then with this screen sharing application that I'm using for this webinar, every now and then I need to move the screen so that it realizes I've changed screens. Okay, so bear with me. So now I'm in the detailed bath and skin inspection screen. So there's the information I was telling you, that the showers, fingernails, toenails, who's doing the hair, all that stuff, and it can all be color-coded, whatever colors you're comfortable using. And then you have the skin inspection here as well. And as part of the skin inspection, you can identify all of the body areas and any potential skin problems. So if I click on that table, I'll just tap anywhere on the table, and it pulls up a list of all the body areas, and I can identify where there's skin problems. I can say, okay, there's redness on the shoulder. And when I do that, it allows me to draw on this drawing, and I can say there on the back of the right shoulder, and I can save that image as part of my observation. Okay? And then I also can identify the cleaning and trimming of fingernails and toenails. And I can also, if you so choose, I can record the weight here. And you'll notice there's a history link. I have a whole history of the weight. So I'll go ahead and record that weight. You'll notice, by the way, this little warning message, the weight that's been recorded is more than 5% different than the previously recorded weight. Now that's important because you may be typing it in wrong, or maybe one day you thought you were typing it in pounds versus kilos, and so it's giving you an alert to this situation, or there may be some serious weight gain or weight loss going on that you need to pay attention to. So if you continue there, what that then has done is alerted again the RPN to that situation. It's sent two alerts actually. One because of the skin issue on the shoulder, the other because of the weight variance. So now the nurse needs to get involved. And now as the PSW, I can mark that task as complete because I'm done with it, and it now turns green. So now let's log in as a an RPN, and let's see what her experience looks like. So now I'm saying I'm an RPN, and if you recall, Darren, I was working with Darren, I was working with Marion, I was working with various residents. So the RPN has her set of tasks to do as well. And if I just go to the tasks list, here's a complete list of tasks regardless of resident. Now take a look. You remember that about 30 seconds ago I recorded an abnormal weight for Ben. There is the abnormal weight alert. So the RPN can go in here. The RPN can review the entire task that was recorded by the PSW. They can even see the skin issues and see all the data associated with that observation, and then can mark that task as complete. She or he has now acknowledged that weight situation and addressed it. They could have entered some comments there if they needed to, etc. Same with the shower and skin inspection here. This was related to the fact that I actually had redness on the shoulder. So maybe I've dealt with it and I'm making some comments, and comments are available everywhere. You know, I've dealt with this, blah, 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 and done this and that, da, 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 da. So comments are always available in these screens for every single worker. And also, while I'm logged in as an RPN, you'll notice that RPNs have access to head injury routine because that's a registered staff task only, and same with pain tracking or pain monitoring. So I'll just show you quickly those two items, and then we'll move on. Head injury routine. Now this head injury routine, what I'm going to do is do a 927 recording, diastolic 120 over 80, pulse 75, respiratory 15, respiratory 15, pupil size, so here we go. These are real pupil sizes, right and left, 4 and 5. Pupils, responsive, reactive. So all these pick lists that you see me picking here, these are the standard default ones, but we can make them be whatever you want them to be. Not everybody has exactly the same pick lists across the province or across the country. Overall condition. This happens to be something that Miller is near and dear to Miller's heart, is the ability to mark, in the end, stable or unstable overall condition. And if I was to mark unstable, then that would automatically get escalated to other people potentially. Okay? So there's different triggers within this head injury. So you'll notice at 927 there I have that recording, etc. And if I'm done for the shift, I mark the task as complete and head injury is done. If that was a brand new head injury routine, then that would have been a brand new initial assessment, and then all of the time slots would have been stamped out based on that initial assessment like I showed you in the PowerPoint slide. Pain monitoring is very similar. You'll notice here in our demo data we have some sample data that somebody's been entering. At 1746, some pain monitoring information was entered. And you'll notice the way, by the way, that I can scroll back and forth. I have a whole history here I can see, all within this entry screen. So I'm going to add a new one at 1337, and I'm going to say the pain score was whatever. Let's say using grimace face 10. Effective medication. Again, these are just values that you have decided to populate as part of these pick lists. We can make them be whatever you want them to be. This happens to be Trinity Village's pain monitoring. And so now it's recorded the 1337 observation time slot. Okay. Now you'll notice I can't go back. You'll notice some of those time slots in the past are historical. They're grayed out. I can't go back and change those. I'm entering from this point forward, so I can't go and start editing other people's data. And if I'm done pain monitoring, I've made at least one recording for the day, for my shift I should say, then I can go ahead and mark that task as complete. And then you'll notice that the RPN also has a whole bunch of review tasks. Now this is interesting because the review tasks are an important part of the overall task. So for example, on the skin inspection is done by the PSW, but there are things that the RPN needs to populate as well. So if I go into Jennifer's review skin inspection, first of all, the RPN can see what the PSW entered here, and also the registered staff needs to answer their own set of questions. So in this case, is a treatment plan in place? Is a new treatment plan required? Was visual inspection of the nails done by the PSW? Was the nail care been completed by RPN? No. And I can put comments, complete, and it's done. So it's the same concept as anything else where you take a task, there's a PSW portion, and there's an RPN portion. Okay? So sometimes the PSW won't get their portion of the task done, and the RPN is blocked from doing things. So there's a whole workflow mechanism built into this system that says, does the PSW need to finish the bath and skin inspection before the RPN can answer his or her questions? Yes or no? If yes, then I wouldn't have been able to answer those questions yet. I would have had to have waited for the PSW to finish their portion, etc. So we take tasks and we break them down into bite-sized pieces from a data entry perspective, but also from a workflow perspective. One more thing I want to show you in the app, and then I'll go back to the PowerPoint. Let's say that you want to know who is all on dementia observation, or who is all on a certain type of restraint. Well, you click on the little forms button down there at the bottom, and you get a list of all the different forms that I've been talking about. So I can see who's on head injury routine. There's two people. You see the green 2 there, head injury routine near the middle of the screen. If I click on that, it tells me who the 2 people are. There they are. And I can do my documentation right from here. Who's all on dementia observation? I only have one resident. Keep scrolling down. Who's all on various restorative care? Who's on pain monitoring? And I can click on any one of these items, and it shows me the list of the residents so that I can do my documentation accordingly. Now that's very powerful just by itself. Who's all on DOS? Who's all on elopement risk? Who's all on head injury? People who know their residents who are regulars, yeah, we know. They know their residents inside out. But the floaters, the flex staff, they don't necessarily know their residents. So they need to come into these different screens to get who's all on DOS? Who's all having a bath today? Look, there's 5 residents having a bath. If you're the type of home that has one PSW dedicated to providing baths, This is very handy. These are all the residents in the entire Pine Woods unit that is having a bath on this day shift. Okay, enough in the app. Let's go back now to the PowerPoint slide and continue on, okay? So just give me a minute to disconnect again and reconnect the PowerPoint. Okay, so now we're going to get into, I have a few screenshots of some example reports. Assisting me in this discussion is going to be Laura Schmidt, who's the internal clinical auditor at Trinity Village. Let's start with the first report. The first report is a very simple dementia observation screening report that's basically taking all that data that you saw me entering and basically print it on some output that looks something like this. 7 days across, every half hour going down the left, and the observations that were recorded. Laura, you want to comment?
Yeah, so just while reviewing our DOS, the BSO team, registered staff, and physicians can make informed decisions on the information that's now more accurate, timely, and easily accessible. So, for example, we use this to help reduce antipsychotic rates within the home, as we're able to capture and review data not only over the 7-day period, but over months to determine the course of action in providing care.
Okay, let's go on to the next example report. Here is dementia observation screening analytics. So this is, this is trending. So you can see here for this resident, by the way, the resident name has been anonymized. You can see there, resident 112. Well, that's actually a real person. You can see during the months of June, July, August, September, the number of days they were on DOS, and the observations, the number of times they were observed. 28 times they were observed as a 1, which is sleeping, in June. 67 times in July, 41 times in August, and the average number of times, etc. And all of this, of course, can be charted with trending charts, etc. The point that I'm trying to make here is you've got this data now, you can analyze it how you see fit. Laura?
Yeah, so once again, just it's using our interdisciplinary team to review all of the information that's now easily captured and make informed decisions so that we can better care for our residents.
We're seeing some questions coming in about can these reports be printed and all that stuff. Yep, we'll address all those very shortly, okay? We'll address those questions. Here's another report that we call the Detailed Observations Report, and have a look at the very first resident there, resident 11. 10-pound pressure. You saw me doing 10-pound pressure, remember, in the app? You remember that at 7 o'clock, 8 o'clock, 9 o'clock, I had to record my observations? Well, you'll notice that it tells me when that observation was actually recorded. So this isn't the data I just entered. This is sample data, but the 7 o'clock observation was actually recorded at 10:23, which is 203 minutes beyond when it should have been entered. And there's the value that was selected, applied, checked, and calm. At 8 o'clock was done at 10:24, which is 144 minutes late, etc. Overall, over the entire shift, that staff member was on average 72 minutes late for their observations. Now, that's actually very good. When Trinity Village first started, this was several hundred minutes late. And in fact, before Vital Hub, before the VH LTC app came in, a lot of the staff weren't recording until the end of their shift, and I'm sure that's the case in some of your homes. They wait till the end of the shift to record. Now, on average, they're recording 72 minutes after. That's an hour and change. That's not too bad. That means our data is going to be a lot more accurate. Laura?
Yeah, so like you just said, it does provide information confirming accuracy as well as insight into our staff workload. So we can also run reports for documentation that's been missed, because you can see what has been entered by each staff member for their observation, and we can really capture the safety feature that was missing with the paper form.
And then we also have we used to call it the tomorrow and beyond report. We now call it the workflow report, or I'm sorry, the workload report. The workload report tells you what's coming up, which workers have what residents to do what for in whatever period into the future. So when you run this report, you can select the date range, you can select the unit or the resident or the type of task, etc., and you can see a complete workload analysis of what's going on, how much work you have upcoming. And Laura, I'm just going to skip to the next one real quick, and you can comment on them both. This last one is a bath schedule. So the bath schedule, of course, is an output of what was entered as the schedule, so you can maintain this schedule within the system. Laura?
Yeah, so this bath schedule drives our skin inspection schedule, which is the vital tool that we utilize here, and Andre did go over it earlier. When a change is applied to the bath schedule, it can be implemented immediately as this uploads to the live version on the houses, which is a much nicer update and immediate action to updating it on the paper, taking the paper to the house, and then informing all the staff that there's an update. You're really cutting out at least 15 minutes of work time.
Okay, now let's hear from Miller now, who's the Director of Resident Care at Trinity. He's going to talk a little bit about, now that they've deployed VH LTC, and again, I'll just remind you, they call it Docket, so you might hear Miller refer to it as Docket, 1 year later since the implementation. Go ahead, Miller.
Thanks, Andre. Hi, everyone. So far, so good. The VH LTC innovation presents to us an enormous opportunity in Ontario to be the leading pioneer by embracing these advanced solutions to enhance the care delivery, at least in these 3 ways. Next slide, Andre, please. First one is better staff or user experience. We performed a 1-month evaluation last year. We had surveyed on the first week and then repeated on the 4th week. The question we asked the user was, on a scale of 0 to 10, how likely do you prefer to use this application compared to the manual papers to organize and document your work? The outcome was the average rating was 9.5 by the PSWs. The average rating by the RPNs was 9. The lowest ranking was 8. Staff member who ranked 1 on the first week actually ranked 10 at the 4th week. I'm just going to let you know some of the comments on the first week. From a PSW, this one says, I like the DOS on the iPhone because it's handy and I don't need to look for the binder in order to complete. Another PSW says, you can do it in any time. Better manage time. You do not have to wait for the other staff member to finish. One RPN comment says, I can see what the PSW chart live because they are charting anywhere close to the time when something happens. At the 4th week, some of the comments is this. The PSW who ranked the question 1 at the first week said that she likes the convenience of having it on the phone. Once I'm familiar with how to use it and where to find the apps that we need. She then scored 10 at that 4th week. For the second, documentation time savings which result in more resident care time. We performed the evaluation prior to the implementation, at the 1st week and at the 4th week. The question was, during your shift, approximately how long in total would you estimate your spending time on documentation prior to the application implementation? And then we repeated this question on the 1st week and at the 4th week. This is the result. By the 4th week of the pilot, there was an average of 23 minutes saved per PSW member. At that time, the RPN actually saved an average of 1.5 hours during the course of the day. This actually exceeds our time savings goal of 12 minutes per staff. Some of the comments during the pre-implementation, the PSW stated that a lot of wasted time while waiting for residents on toilets. The first week during the implementation, the PSW stated, I am able to chart now whenever instead of coming back to the nursing desk or the wall computers. At the 4th week, an RPN stated previously I was not able to take my assigned break, but now at least I get my break. The third point there, improved data accuracy through safeguard based on best practice for better outcomes in quality care and compliance. We performed the evaluation prior to implementation using hard copy form and then compared it at the 3rd week mark using the VH LTC application for the 3 forms. These were the DOS, the restraints flow sheet, and the skin inspection. An observer stayed with the resident subject the entire time and also completed the same assessment the staff performed. So that's how we did it. The outcome was the total improvement for accuracy was from 48% to 75%. There was an increase of about 30% for accuracy. So the impact of this, for example, with the DOS being more accurate, it also improves reporting for responsive behaviors to RPNs and BSO teams and allows for more careful monitoring for antipsychotic medication efficacy.
Miller?
Yes?
I just want to do a quick time check for everybody's benefit. We're ready to move on to your next slide of efficient and well-informed decisions. Would you be okay if we spent a few minutes now answering some questions first and then move back to this? Are you okay with that?
Yes.
Okay. So what I'm going to do is I'm going to leave it at this slide, 1 year later, efficient and well-informed decisions. This is an interesting thing Miller wants to spend a couple minutes on. But there's been a number of questions in the question panel that I just want to touch on very quickly before people have to leave. So some people have been asking, do we link with point-click care? The answer is yes. This integrates with point-click care. All your resident data goes back and forth. There's no need to be manually entering data in VitalHub other than the documentation itself. You're manually updating, of course, your chart information, but all the resident information comes from point-click care. There's a question about cost of the system to install it and then maintain per resident. I won't actually give you numbers on this call, but we will follow up with you. The way we price it is there's an initial implementation fee, which is minimal, and then there's a per resident fee. So it's per patient day, similar to the way point-click care prices the point-click care product. There was a question about what documentation systems does Trinity use for the assessments, and they use point-click care for the RIMDS. Miller, is there anything you want to expand on that question for RIMDS? What modules do you use? Miller, are you there?
I'm sorry, kind of missed the last part there.
The question was, what documentation systems do you use for assessments to auto-populate other modules, so RIMDS, for example? So you use point-click care exclusively, right, for that?
Yes.
Yeah, okay.
That's about it.
There's another question about, can the assessments and reports be printed or available online for analysis? Either or. So everything I showed you there in the screenshots was available to physically be printed. It also produces a PDF if you prefer, an electronic PDF. You can even, if you want, attach that back into point-click care to the resident's chart. or you can not print anything and not produce anything and just view it all on the screen. What system do you run for your EMAR, and can VH LTC link to EMAR? So you want to talk about EMAR quickly, Miller? Miller? I think you're on mute.
Sorry,
Miller.
Andre, can you just repeat the question?
What system do you use for EMAR, and does VH LTC link to EMAR? So the question, first of all, the second part of the question, does VH LTC link to EMAR? No. There's no link to EMAR in VH LTC. It does not deal with medication administration at all.
No, yeah, like I would just say the best way to think of this is that this is getting rid of your paper charting. If your paper charting is for your medications, then that's like, this is not what this is dealing with. This is just for your assessments at the front line. I guess is the best way I would describe it.
Thanks for that. Then the last question is, did you provide the home with iPhones for the staff, or are they expected to download the apps on their own devices? And the answer to that, I can answer that, is the iPhones were provided. Typically, most homes prefer to provide these devices for work use because they're controlled as to what you can and can't do on those devices. Don't think of it as a phone. Think of it as a small little computer that you put in your pocket. And you're not going to ask employees and workers to bring their own computers in. You typically aren't going to do that for the phones either. So these are smart little computers that they walk around with, and typically you provide them. And we are turnkey. VitalHub takes care of all that with you, leasing the phones through Apple, or the maintenance and care package with it is taken care of, support for them and all that stuff. So we're not expecting you to go and figure all that out on your own. Oh, and there's one more question here. How have the PSWs adjusted to the transition from paper, and did the training process take long? Laura or Miller, you want to comment on that?
Hi, Andre. So right from the get-go, we had involved everyone, especially including the front line, RPN, even the RI coordinators. And we brought it to them, and we had involved them in the process, even with the forms. We asked them how to do things. We asked for feedback, back and forth, and then we chose some dates that's workable. We started with the day shift and worked all three forms first, and then we went to the evening shift and then the night shift eventually in the whole house. Then moved to the next house.
So it does take a little bit of time initiating, but maintaining is fairly easy because it's just capturing those new staff when they come in, and all you'd have to do is capture them during orientation time. And then when there's new forms, you just have an update that's sent to all of your staff.
One last question. As each facility has different policies and the assessments might differ between the facilities, can the tools be created for each facility? The answer is yes. Each facility within VitalHub is treated like a separate item, and forms and layouts and permissions and reports and you name it can all be controlled at the facility level.
Can I make a comment on that?
Yep, go ahead.
I just wanted to say, you know, we're all providing care and offering, doing best practice, and a lot of money is always being spent on that in the healthcare system. So in some ways we would like to learn from other people too, but it would be nice if we all followed the same processes and for better outcomes too. So we do it more collectively and we're all on the same page, you know, trying to provide the best care. What is the best care?
And there's a few more questions coming in, but I think what we'll do is we'll individually respond to those people who are sending some more questions in the interest of time. It's currently 2 o'clock. We, in order to finish Miller's part, and we want to talk a little bit about some next steps, hopefully most of you can stay on the line for maybe another 10 minutes. If not, we completely understand, and thank you for joining us. And for those of you who can stay another 10 minutes, let's now get back into Miller's 1 year later conversation. Go ahead, Miller.
Thanks, Andre. You can actually move to the next slide. It's about the efficiency and being well informed to make decisions. So the first one would be helping the CQI program. First of all, we know that collecting data like the assessments are now more reliable to us and it's at fingertips. For example, determining the number of DOS per house at any given time can easily be taken. With this data during the CQI meetings, our process has improved as we can better analyze and prioritize our risk to better direct our resources. For the second part, supporting the programs and committees through improved data reporting and analytics. The committees are able to access the data pertinent to their goals to focus on resident-specific needs in a timely manner. Having the reports online and the easy of sharing of information, we also improved on including interdisciplinary team members to ensure continuity of care for our residents. Next slide, please, Andre. The next step, I think we were discussing a bit about standardizing these forms that Debbie was saying. We know that many homes have different versions of DOSes, and that's the beauty about it because we can collaborate and take the best practice guidelines out there. For example, right now the BSO is coming up with specific items on what the DOS should look like, so we should be able to have one DOS for all homes. Once we standardize that, we know that there's an ability to review the gaps of the workload measurements. As you know, right now in RIMDS captures for the funding, but the other part of workload that I see that's not captured are the number of DOSes, the number of head injury routine, the number of forms that are being done in the homes for specific residents, and it clearly doesn't reflect much on the RIMDS. And Andre, if you can take over the spread to other disciplines and product enhancement.
Yep. So one of the things that we're working with Trinity and other homes on is spreading the solution beyond nursing. The tool is designed for interdisciplinary communication, as I've shown you with all these alerts and automated creations of tasks and schedules and so on. So what Trinity is looking at doing is spreading this to the programming and rec staff and then nutrition and even the physicians. Actually, the physicians is happening as we speak, so it should be at the top there. But programming in particular is, if you look at the product enhancements paragraph just underneath that, where I'm articulating there that from a product perspective, we're putting in some improvements to manage programs, events, and outings. So what you're going to see in the spring of 2019 is the ability for the rec staff to create programs, events, and outings and have attendee lists, kind of like similar to what you can do. It's a combination of what you can do in Activity Pro and a little bit in Point Click Care, but what this does is it projects its outing schedule onto the PSW's task list. So if I create a Tim Hortons outing and I need these and these residents that I know are going to join me, and then I want to be able to track attendance real easily, that they did come with me to Tim Hortons, but not only that, before they have to come downstairs to get on the bus, that the PSW who's responsible for those residents knows ahead of time that at 10 o'clock today, Mary needs to be downstairs with her runners on and her coat and hat on to go to Tim Hortons. So that information then gets communicated back to the PSW. So the full integration, full circle integration of activities and events and outings. And on the, excuse me, on the nutrition side, things like if a resident is not showing up to the dining lounge for breakfast, lunch, or dinner, that the PSW will get alerted to that fact to know that, hey, I need to go track down Mary because she's not in the dining lounge. So things like that also. Or if the resident was out at Tim Hortons at an outing and they had a donut or a coffee, that information ends up getting back to the group so that they know not to provide the nutrition or the snack in the afternoon because they may have had it already at Tim Hortons. Or when they're at Tim Hortons, that the rec staff can record some of those dementia observations or other observations that may be recorded, because that's a missing, when they're gone for 2 hours, those are gaps in the observations that maybe you want to do as well. So the whole concept of integrating it to the other disciplines now is that next step. And the third bullet in the product enhancements paragraph is additional form layouts as needed. You notice we put that because it all depends on the customers. So if you have some very specific forms that are laid out differently than we already have, then we'll create that for you. The picked list items, which items appear, and the text and the labels and the questions and the selection options, that's not a big deal because those are all configurable by customer, by facility. But it's if you have a whole brand new layout of a form that we want to put into the system, we'll put that into the system, so we continually do that as we get more and more customers. So we hope, unless there's further comments from anybody, we hope that you enjoyed this, that it was informative. And Debbie, thank you to you and the Trinity team there for joining this, really very much appreciated. And if anybody on this call has further questions or wants to get into more detail, have a personalized demo, we're happy to come on site and show you more, even show you more about what Trinity has done or others. Reach out to us at sales@vitalhub.com, and we're happy to respond and follow up with you. Okay, thank you very much, everybody. This will end this webinar. Very much appreciated, and have a good rest of the day. Bye-bye.